demonstration commences.
Start, we're there now.
Right, I think we're in now. Hello, everyone. Thanks for joining our Civica Liver Surveillance Seminar. Glad to see there is quite a big turnout today. So what I'd like to do is, we've obviously got cameras on to show myself and colleagues. And what I'd like to do now is just bring up a slide deck that we'll work you through initially. So bear with me a second. We'll get there. Go. Lovely. Right, it'd be great if a colleague would actually just indicate if we can see that now. Great, thanks. So yes, thanks everyone for coming along to see our short presentation and demonstration of the Civica Liver Surveillance Solution. My name's John Kyle, and I'm going to be accompanied today by Spander Joshi and also Louise Buxton from Civica, and I'll go into that in a second. So broadly, our agenda is in the next 45 minutes or so, we'll do a little bit of an introduction. We'll then move on into a bit of a presentation around Civica and the clinical pathways and Infoflex overall solution. And then Spandon will be demonstrating live our actual liver surveillance design. That will be the sort of bulk of our time today. And then there'll be time afterwards for a bit of a Q&A and a generalised discussion. Everybody on the session is muted currently, just because of the sheer number of people on the call. But if you have questions or you think of questions while we're talking, please submit them via the chat screen and we'll sort of make sure we revisit them as part of the Q&A at the end. Okay, so who are we? Well, I'm John Kyle. I've got the role of Cancer Account Manager, and I've been with the Infoflex team now for, I think, 19 years or so. I've been involved in lots of different clinical implementations around the country in different shapes, ways and forms. And I'm currently focused on the Civica Cancer Alliances, who we work very closely with. My colleague Spandon Joshi is our clinical product advisor. He has got an even longer breadth of experience with Infoflex, and he's our sort of key clinical advisor, and also he has been very closely involved in the design and implementation of this product. Louise Buxton is our cancer manager. Again, very, very long pedigree of experience working both with the Infoflex product and also on the NHS cancer management side of things. So she brings a lot of experience to bear here. And last but no means least, Karen in our marketing team has set all this up, for which thanks. And she'll be sort of managing a lot of the things behind the scenes on this call. Okay. So, Civica Clinical Pathways. Now, for those of you who are not aware, that is the new branding for the Infoflex product, which has been around for 25 years plus. And in that time, it's been well established for use in around 120 NHS trusts across the UK. We have got tens of thousands of users using Infoflex for quite a wide variety of clinical specialties. As you can see there, at the last count, we had 65 plus different departmental and specialty solutions out there. Currently, we focus on cancer, but we also have solutions for IBD, colposcopy, endoscopy, hold on a second, MS, and there are quite a wide variety of other solutions out there. And essentially, what the reason we can do this is that Infoflex, or Civica, or Clinical Pathways, as it's now known, is an information toolkit that allows any patient pathway to be modelled very accurately and at a very detailed level. And that has allowed us to get very well established in the NHS. Here we go. And just to illustrate the sort of the geographical reach of our solution, you can see there a number of different NHS organisations that we have long-standing and extensive relationships with. in the UK and also in the Republic of Ireland as well. And we'll be talking about some of those different customers today. To give an example, particularly in the sort of cancer arena of large-scale shared care projects we're working on, we have been working with the Kent and Medway Cancer Collaborative for well over 15 years now, as part of their information management strategy for cancer. The Kent and Medway Cancer Collaborative is effectively, or in my view, the operational arm of the Kent and Medway Cancer Alliance, which covers 4 acute trusts, and they essentially use Inflex for cancer all the way, originally for cancer wait times and COSD functionality, but over the years they've extended that into MDTs, lots of different tracking modules. We've moved into the stratified follow-up arena, where we've set up a patient portal there. And more recently, and of great relevance to this session today, we have got a targeted long health check solution there, which has led on to us setting up liver surveillance. Moving on now to Greater Manchester, a very large cancer alliance there. We've been working there for, I think, 4 or 5 years, primarily in the personalised care space, but also in an area known as the Single Queue Diagnostics Project that some of you may have heard of. So again, within personalised care, focusing very much on initially on the national agenda, on breast, colorectal and prostate. But now that's encompassing, I think, around 12 different tumour groups that we are extending the design to. So quite a large rollout there in terms of the breadth of functional coverage, and also a very large rollout in terms of the different trusts involved, because that's a huge, big area. Single Queue Diagnostics is probably worthy of a webinar in itself one day, but that's essentially a program of work to really establish the idea of moving diagnostic testing away from something that's being managed locally in terms of resource management into something that's managed out of a single resource pool, i.e. a single queue. And that's a very interesting and very transformative project that we're working on as well, cancer area. And then finally on this slide, we're working very closely with South Yorkshire and Bassetlaw. That's the sort of Sheffield, Rotherham, Barnsley sort of area, and traditionally they all worked with Inflex for cancer in their own trust, but due to the I guess the heavy number of patients that move around that area, they are very keen to move to a single cancer record for that entire area. So a bit of a big transformation project, but it's something that will actually deliver a huge amount of benefit over time. So the Civica Clinical Pathways Cancer, or just for brevity, Inflex, what do we get with that? Well, as part of the standard package for cancer and associated solutions, we have Inflex. Core to it is a tracking and pathway management functionality, and that really has grown from the traditional side of cancer tracking and monitoring, MDTs, moving into newer areas like best practice time pathways, NSS, and again also fairly recently end of treatment summaries and patient stratified follow-ups. In the arena of personalised care, we have a number of patient-focused tools that use the same data model, including PROMs and PREMs type things, HNAs, and we've got along with that is the ability to generate care plans and also share data further down the line with areas like primary care and the community. And also with this, we've got a very strong analytics and reporting module. Our sort of reporting takes 2 forms. Where there are national reporting requirements, Inflex will do that out of the box for things like cancer wait times and COSD. I need to update this slide actually because MBOCA and NOCA are no longer separately required. They've all been folded into COSD. But so any national reporting will be done out of Inflex without any further configuration. But we have sufficient local reporting functionality that we will train all of our key users to be able to generate their own reports as well. Key to the success of any clinical implementation, and certainly it's been a massive factor in InfoFlex's success over the years, has been systems integration. We have our own integration tools. We don't rely on third parties, and we will receive data and send data to systems such as PASIs, EPRs, Path Radiology. The list is extensive, as you can see there. But yes, we can receive data, we can send data, and we can send files as well, such as documents. An emerging area is dashboards and service monitoring. Spandon will be able to demonstrate some of that today as part of his cover. But we'll look at KPIs for any sort of operational area, and we can prepare clinical dashboards around that. Now, last but no means least, and the reason we want to focus today is our screening and surveillance capability, which really is a sort of logical part of our overall pathway solution. So initially, as I said earlier, we started off in the targeted long check area. We did a pilot with the Royal Brompton in London, and subsequently that has been taken up by Kent and Medway, which I'll talk about in a second. And here we are today to talk about liver surveillance, which will go into some more detail. Okay, just to kind of almost present that information in a slightly different format, where what this shows is our overall coverage on the cancer pathway. Traditionally, for a lot of organisations, this started on the orange box, the referral for cancer, or referral for suspected cancer, if you like, and how that's been tracked and managed throughout the entirety of the cancer pathway through diagnostics and treatments, and more recently into the personalised care space. As you can see here, I don't know if you can see my mouse, but on the extreme left-hand side, this has been quite a new area for us, as the National Early Diagnosis Initiatives have led us to develop solutions for initially targeted long checks, and also now for liver surveillance. But it all fits within one overarching model for us. There's not a separate data model. So any information collected at the surveillance stage is then available further down the line. And that's a very powerful approach. Some of the key benefits we find with an InfoFlex solution are, and I think it's very much highlighted by liver surveillance, is it's a future-proof solution. It's very adaptable, the toolkit, and the way that liver surveillance came around was that the people who were using InfoFlex could see the relevance and adaptability of InfoFlex to pick up the new liver surveillance requirement. Real-time patient tracking lists are implemented throughout the pathway model, and we'll show you some of these as part of our demonstration. As I say, we also have a very strong integration capability, and I think that makes a huge amount of difference to clinical users, knowing they don't have to enter data twice for any given scenario. And we also, as I say, it's a single patient database. The data is not being entered into silos. If the data is entered once in InfoFlex, it is available for use subsequently. And in terms of deployments, we have everything from a single user models out there to trusts that have us in use for hundreds and indeed thousands of users. So we can always deploy at a small scale and grow in the background as needs develop. So a little bit about where we are with liver surveillance before I hand over to Spandon for the actual demonstration. Just a little bit of a narrative here. The background to this was we had some early conversations with the National Early Diagnosis team, and almost as a coincidence, but in parallel to that, we were talking to Kent and Medway, who they had just completed their successful rollout of the targeted long check. They knew about the liver surveillance requirements, and they could see there was a lot of similarities between that and what InfoFlex was already doing for the targeted long check. They were currently running things, as a lot of people are in areas, based on a sort of spreadsheet-based approach, lever arch binders. They were all being done separately at the 4 different trusts in the Kent and Medway area. And they were keen to move away from that to a single centralized solution that was capable of generating the national stats that are required, but also, more importantly, to be able to manage the existing population of patients. When we spoke to the Cancer Alliance about this, they were a bit nervous about how the individual provider trusts would react to that, because the liver groups hadn't previously been an integral part of a cancer pathway. But what was pleasantly surprising for everybody was they were very keen to start using a solution if we could help them with it. And so we undertook a collective process of building there and understanding a common process model. They developed their SOP to fit around that. And then we came in as part of the project and we built their design prototype based on that special interest group. And we are now in a situation, and really, we started there probably in December time, and we're now at the stage where we're just about to go live there. So it's been a very fast-moving project, but we've I think we've just got sort of full clinical sign-off to move ahead with that now. So it's a very fast-moving initiative, but everybody's incredibly enthusiastic about it, and I think we're going to show a lot of success for that shortly. So without much ado, I'll come back to that later. I'd like to hand over to Spandon now, who will be able to show you the actual InfoFlex solution himself. Is that okay, Spandon? Will you be able to pick up the screen share now?
I'm going to switch off my camera. Thanks, John. Yeah, and unmute myself and start sharing too. So, sharing my screen, if you can see the login screen. Yeah, perfect. Lovely. Yeah, great. Yeah. Right. Yeah, let's crack on with the demonstration of the solution. So my name is Spandon Joshi. As John introduced me, I'm a clinical product advisor. And this is how we have compiled the liver surveillance solution. So once you log in, you come to a dashboard page. Now, as John indicated, we have got a couple of surveillance programs as a part of the package. Obviously, we are demonstrating liver surveillance today, but we got lung surveillance as well. And based upon your login credentials, you would land on this particular dashboard page. So I'm tied with the liver surveillance design. So I land on to liver surveillance dashboard page. So very briefly, presents KPIs on the left-hand side, and the tracking list in the middle, and then the reviews, which are part of surveillance program, such as today's review list. Reviews due next week, next month, and next 3 months are all bundled on the right-hand side. This is followed by further KPIs presented as pie charts. It's broken down into risk category, or high risk or standard risk. This is invitations sent for the liver surveillance and those that are still not invited. And this particular chart shows negative outcome versus positive outcome, and those diagnosed with hepatocellular carcinoma. We'll come back to this. So the essence of dashboard is that every piece of information, all KPIs, all charts, your tracking, navigation is all set here. However, one could go to patient search, select a patient by entering NHS or hospital number, and select the patient. So once you select patient, you come to another dashboard page, which we'll call patient dashboard page. And you could choose a pathway, again, based upon your login credentials. I'm going to select liver surveillance pathway here. As we know, these are the headline details for the patient, Brenda Jones, and there is no liver surveillance pathway being created. So I'm going to create a fresh, which brings a liver surveillance referral screen. So what we have done is we have mapped the entire process pathway and laid out into screen. So we got 4 screens. Basically, the journey starts from referral, journey ends with the surveillance management or post-surveillance management. So I'm going to enter some data here to show how referral details are captured. So I'm going to start with last year, 2023. And that's where the referral was sent, referred by. We got number of options, could be referred by GP, community care, hepatology clinic, and occasionally it could be self-referral to hospital referred to. We got a list of hospitals, so part of our dictionary. Referral was received on the same day. This is the category, which is priority. So I'm going to select routine, any risk factors associated. And this is a list of risk factor, includes alcohol intake, smoker, drugs, obesity. Seems Brenda loves her drinks. And this is the piece of information where often FibroScan has been done prior to the referral. And if that is the case, you could record previous FibroScan details as well as the FibroScan results. I'm going to put that slightly before in December and a result. And this is where we determine whether the patient falls into high risk category or just a normal risk, standard risk category. And this is automated, such as if you put cirrhosis or advanced fibrosis, the high risk category is selected. And then this is a further management post-referral when we wanted to invite a patient to liver surveillance program. So I'm going to start that next day straight away. So it brings to the next screen, which is surveillance details. So again, simple details such as surveillance status, surveillance start date. We have invited on 2nd, so I'm going to drop that date here. So surveillance start date. Now, this is interesting. Surveillance status is automated and is selected a value active, but we got number of options available. If patient goes on holiday sometimes during the pathway, then we could choose off pathway. If patient is diagnosed with HCC, patient then has a status change to refer to cancer team. Similarly, fatty liver, cirrhosis, anything associated with liver team, then patient can be referred to hepatology team. Patient can be discharged or deceased. So as a default, we got active status. The FibroScan result is available straight away from previous FibroScan result. And if patient has cirrhosis, we have a list of options to determine what was the reason behind. So here I'm going to select, say, Hep B as a result. Any other comments, go here. We got this FIB4 value entering facility, and there's a link as well where you can determine how you calculate your FIB4 value. So then the next screen is going to be current review. There the actual surveillance starts. So I'm going to drop the date when the surveillance started. Once I enter the review date, entire screen is enabled for me to record further details. So we got 2 tests here, FibroScan and alpha-fetoprotein, and these are kind of routinely checked as a part of the guidelines. And one could view guidelines by selecting the guideline button here, which means that how patient moves from one area to other area, and within the surveillance virtual clinic, how these tests are performed on a regular basis, such as 6 monthly. So this particular instance, we have just started the surveillance, so I don't have any last test outcome or anything like that. So what I'm going to do is I'm going to say review outcome is scheduled test only. There are no letters to generate at this moment, and review status, I set it to complete at this moment. Therefore, I know now that next 6 months, which is falling on to 2nd of July, my patient surveillance starts. So I'm going to save this, which gives me a list of kind of warnings that this particular screen is going to be cleared. The details captured on this screen are going to record on review history, and review history shows me now a row which says that, yeah, the tests are scheduled on 2nd of January 2023, and the tests are due here as a top line. Details also got updated. So that was the last review. The next review is 6 months after, on 2nd of July for ultrasound as well as tests. So I'm going to come back now on that day, and I got this as the real beginning of the surveillance. So I'm going to say normal, and I'm going to say here normal values as well. Now, if the values are out of the normal value range, I would select modify interval. So the guidelines is all kind of embedded here in terms of a set interval between two surveillance tests. So as per example, for OFB and FibroScan, we got 6 months, which is now July, but the next one is in January this year. But I could override that by selecting modify interval and choose to bring that test earlier or later based upon parameters. So this time I'm going to say review outcome is negative. And I conclude with my surveillance in terms of current review. Once again, few warnings. And when I save, I have now the second row indicating that these were the results, and I'm going to continue surveillance, which is going to be in the first month of January, on the 2nd of January. And again, the top line here changes with the details such as the last review, next review, and my next FibroScan, and so on. This time I'm coming back this year in January, and I found that the tests are not normal. So I'm going to say abnormal. Now this is all configurable. So instead of normal, abnormal, you could have a value, you could have a code list option, and InfoFlex's flexible toolset would allow us to configure screens based upon the local requirements. So I'm going to select 20 now. I guess that's quite high. I'm going to say positive screen, and that requires informing consultant as well as further tests. Therefore, this patient requires biopsy, as we think. So the biopsy is taken. Unfortunately, biopsy is positive, and that's positive for HCC. And if it is positive for HCC, it allows us now to record the stage of HCC. So I'm going to select stage B. Those who are not familiar with the staging of HCC, we got a link embedded providing with valuable information about the Barcelona staging for HCC. If positive, then cirrhosis as well. We could indicate that. And any other diagnosis, we could also record independently. So I'm going to say fatty liver as well. This time I'm going to generate an ad hoc patient letter. Let's say patient needs we go, and I'm going to conclude this episode of the current review. Save my details, and I would able to see now the top headline details changes here, as well as the review is stored as an historical review at the bottom part of the screen. So again, this was when the last time review conducted. This is the date for the next review, which is 6 months after January review, and that's where my review history is recorded, and I could see all the kind of details straight away without going into details. If I want to, I could go into this one of the historical reviews, and I could find out what happened at that time, in kind of quite detailed manner. Along with that, we could now refer this patient to what we call hepatology clinic. But in this case, we are going to refer to cancer team because patient is diagnosed with HCC. So that's when we want to refer patient to the cancer team. So that's where we would say when we are referring this. So we're going to say we refer this patient straight away, actually. The urgency is pretty urgent. So I'm going to say urgent. And so refer information provided to patient, GP, and cancer care team. And the letters generated are going to be for GP at this moment. So I'm going to go and save these details. So we deliberately didn't put the organization carried out just to show that we could put configure alerts, warning messages as we need. So now. So this particular patient now status change. As soon as we change the status history records that the historical status is the first status when patient arrived for the surveillance program. Patient status was active. Patient status on the 27th of March today is changed to refer to the cancer team. So that's how it records all the status as well. And finally, when we find that the patient is diagnosed with cirrhosis, fatty liver, in this particular case, HCC, then this is where we try to manage the patient pathway further from then onwards. So here the details are also kind of shown. So this patient was part of the surveillance program in January 2023, currently referred to the cancer team, and these are the reasons. So here, onward management wise, we could now choose to refer to liver MDT for discussion. That means we got date allowed, date field enabled. I'm going to place today's date, and then any of the notes and the surveillance management plan gets recorded here. So that's how the pathway kind of model here. 4 screens starts with referral and ends with the surveillance management program. The top headline here always shows you when the last review was conducted and when the next review is. And this is all part of the patient list. So all of these cyclical kind of surveillance tasks, which you can track through patient list, either review due. So this is the liver review due within next 3 months, then it gives me patients. So one doesn't really need to go through the patient search. One could go through fetching one of the patient list and then just select those patients that require testing. Similarly, we could track patients through status as well. So this gives me all the status, but I could select a patient with a particular status here, active, but I could choose, give me all the records that are referred to the cancer team. And when I submit, I get these records here. And all of these can be taken on the Excel. The next interesting bit is analysis. And we got several analysis categories. One of them is all of the referrals within a period. If I select dates, it gives me all of the referrals. I could take it on Excel and perform further analysis. Similarly, patients with risk factors, again, within a period. And these are the patient risk factor, and risk factor are listed in the last column. Similarly, high risk patients with the associated risk factors, where the patient has advanced fibrosis, cirrhosis, and so on. And it goes further to invitation sent, actively surveillance patients, and those who are diagnosed with HCC and other analytical kind of numbers and data, you get it. And as I said, every time you get this analysis published here, you could take it on Excel and perform further analysis. Finally, going back to the dashboard page now, hopefully make more sense. These are the KPIs, as I said. And all of these pathway model into 4 screens, as I've shown, can also be tracked here. So referrals awaiting liver surveillance invitation, as per example, where the pathway begins. These are the patients invited, but the surveillance hasn't really commenced at this moment. And this is not just the numbers, but also the list as well. The patient with cirrhosis awaiting referral to hepatology team, patient with HCC awaiting referral to cancer team. So if you select one of this list, you would able to get details here of patients, that the patients are invited, but the surveillance hasn't started. And here you see the column of the first surveillance date, which is empty at this moment. So the tracking options not only allow us to get that patient in this particular category, but also to navigate. Also, it works like to-do list that we need to refer these patients, as per example, to cancer team, and these are the patients waiting to be seen by the cancer team, and so on. And on the right-hand side, as I said, is another to-do list, but this is generally in relation to the reviews of FibroScan, reviews of alpha-fetoprotein. So these are the patients bundled as 2 days surveillance, surveillance due next week, surveillance due next month, and 3 months. So this is how we have kind of compiled our solution, which means that you got a dashboard page, you got a patient dashboard page, patient's journey embedded as the pathway kind of should take patient through, and finally end up with quite comprehensive analysis modules also embedded with the solution. Right, so that's where I conclude my demonstration and open for any questions that you may have.
Thank you very much, Spandan. I must say you've recovered the time very well there. So thanks for that. Just to, this has been Civica talking for the last sort of 35 minutes or so. It'd be really interesting to hear if MD actually attending the webinar. If you've got any questions or comments at this point, you can either unmute and ask the questions through the microphone, or you could paste questions in the chat, and we'd be happy to hear for them.
I've got a couple of questions that came in a little bit earlier.
Okay.
One is that a trust that don't use InfoFlex for cancer currently, can they still use it for liver surveillance only? And the other one was, is this approach suitable for other surveillances on the horizon, for example, pancreatic?
Oh, okay. Thanks for that. So the first one is, we modelled this at Kent Medway. They were an existing cancer user, but it doesn't need the liver surveillance module. Does not need to have the cancer module there. It's a standalone thing in its own right, because obviously only one of the outcomes is a potential referral for cancer. There's lots of other potential outcomes, most of which we hopefully are the patient does actually just stay on the follow-up on the regime anyway. So we could go with either approach. And sorry, what was the other question?
About whether it could be used for other surveillances.
Oh, right, yes. Now that's a good point. This model, this is the second of our sort of health check sort of modules. We started off with targeted lung and moved into liver, and there's lots of similarities there. And we know that there are a line around what's the other one?
The horizon.
Right, yeah. So we know there's a pancreatic surveillance project coming down the line, and this will fit very well with this approach as well. So we think it's quite a good example again of future proofing in InfoFlex. So that answers that.
Well, just to add this, just to add into it is Barrett surveillance as well being asked for, and we would able to cater Barrett's esophagus surveillance program.
Right, excellent. Thank you.
Is the funding pathway for this from NHS England?
Oh, here is there. Now, that's not something, as far as I'm aware, that the funding is NHS England is funding the cancer alliances, who in turn, will fund the solution either directly or via some of the provider trusts. That's the sort of model that we're seeing, if that helps. So yeah, there is funding, but I say that it's coming through the cancer alliances in our experience. We're already talking to some at the moment. If a trust went with Civica for liver surveillance, we already have cancer and IBD modules. Yes, absolutely. We could, we would integrate the design with your existing design so that we can benefit from any pre-existing interfaces in particular. And I don't think there's much commonality between liver and IBD clinically. But yes, we would certainly integrate there. And if you've got an existing platform, then that's great. There will be a pricing will be based on number of users and also the sort of implementation side of things, in terms of what it takes to deploy it locally. Do you know of any systems where the Cancer Alliance has funded this? Yeah, I mean the Kent Medway Cancer Alliance funded the liver surveillance in that area. Yeah. Oh, sorry. Do you know any system? Oh, right.
Funded trusts, I think.
Oh, funded trust, yeah. So that's definitely the funding model we expect to see. The same thing happened with the long check as well. It was the funding came via the alliance, and that's what we kind of expect to see here as well. So that was quite a useful set of questions, and that was from Bedfordshire. Ah, right. Hi there. Good. Okay, that's good. Is there anything else? Anybody? Give us a second. Well, we're heading on down. I think we had 45 minutes, so just to sort of maybe start to close off, if there's nothing else. It's been really useful for us to be able to present in this way. It's something we would like to do a bit more of, I think, over time. If you have got sort of other questions that come up after today, or you want to talk to us directly around what it would, what the implementation options would look like, then please feel free to reach out, and we will be able to put you in touch with the relevant sort of account manager for your area. We're also talking to a number of different cancer alliances around the country, and we're also presenting back to the NHS England early diagnosis group in the next few weeks on this as well, because I know there's a lot of interest nationally in this area. So we have 2 minutes left. Now something has popped up in my window. Don't know what it is. Nope, wasn't this one. Okay then. Right, well, I don't think we're going to get any more questions now, so that's grand. Karen, I'll look to you now around what we do next. Well, I guess we just finish up the chat and we can make the video recording available to anyone after this.